Okay, hello, good morning. Thank you very much for this opportunity. It's my great pleasure to be here today with all of you. So now let's go to the clinic. Let's see if you find this a challenging case. At least it was for us. I hope you enjoy. These are my disclosures. And this is our patient. It's a 53-year-old man with a personal history of ulcerative colitis since 2005. It was under control with mesalazine. He also has psoriasis since 2010 with previous treatments of topicals, acitretin, methotrexate, cyclosporine, apremilast, and phototherapy. And also has primary sclerosing cholangitis since 2015. So here came the challenge. He's currently on the liver transplantation waiting list in our country. And this is our patient. As you can see, it's a moderate to severe psoriasis patient. But when you ask the patient, how do you feel? How are you? He says, I cannot live with this. I don't want to live with this anymore. He has an enormous impairment on his quality of life, due mostly because of the pruritus, which was 10 out of 10. And also we know that primary sclerosing cholangitis also causes pruritus. But you cannot see in the slide, but he also has psoriasis in his hands and his forearms. And he used to work in a food shop there in Spain, and he has a lot of shame in his work. So he was very affected. So we have in our clinic 3 problems to solve. Psoriasis, a skin disease, but the patient, when you ask him, what do you want me first to help you? He says, psoriasis, please. Then we have ulcerative colitis. Our patient was good with that. He was fortunately under control. And then we have primary sclerosing cholangitis. The patient was not suffering so much about this from a symptomatic perspective, but he was, again, from his psychologically, can be also important for the patient when you are waiting for a call to have a transplantation. So these are the problems of our patient. You know what psoriasis is. You know now perfectly what ulcerative colitis is. But what is primary sclerosing cholangitis? Okay, so this is a chronic cholestatic liver disease, which is thought to be autoimmune. Patients can be asymptomatic or have some symptoms, such as pruritus. 70% of these patients have also inflammatory bowel disease as our patient. And unfortunately, no single drug has been proven for this disease. We have liver transplantation. Okay, so going back to our clinic, we have 3 questions in mind. Can we prescribe psoriasis treatments in a patient with primary sclerosing cholangitis plus ulcerative colitis? Can we use our psoriasis treatments, our biologics, in a patient on the liver transplantation waiting list? Can we use our treatments in a patient after liver transplantation? What is going to happen with this patient? So before, during, and after. First one, can we prescribe psoriasis treatments in a patient with PSC plus UC? Okay, on the first hand, we can think, are we helping even the patient or are we making any harm? Okay, it is thought currently that primary sclerosing cholangitis is an immune-mediated disease, so maybe we can be helping him. And this has been studied in this systematic review and meta-analysis. And as you can see here, some treatments such as infliximab, even methotrexate in a liver disease, and also adalimumab has been tested in randomized controlled trials for primary sclerosing cholangitis, not for people with psoriasis plus PSC, but for PSC alone. And as shown here, it has, such treatments such as methotrexate has demonstrated improvements in ALP, in liver test function. So this is really interesting. And also we have, for example, as you can see, adalimumab. Although we know that the quality of these studies is relatively low, we at least know that these treatments are safe in these patients. Okay, another reason to treat this patient. We know that a person with PSC who also have another non-IBD immunological disease, they have a risk factors for a reduced survival, so we can be more prone to treat this patient. And what about IL-17? Well, it has been recently published in this pretty good journal, the Journal of Hepatology, that IL-17 in the cholangiocytes induces PD-L1, and this PD-L1 seems to be protective from the T cells perspective. So they advise us to be cautious about using IL-17 in this treatment. We know that we should be, of course, cautious in this patient with IBD, but more reason and more tips that we have to help our patient. So again, we are here with our patient. We explain to him everything in a good conversation with the whole team. And then, after considering risk and benefits and taking into consideration his preferences and his quality of life, adalimumab was started. And he was a super responder, and in 2-3 weeks, he was completely clear. He was really happy, and he said, now I can sleep, and without any worsening in the liver function test. So what's now? He is clear, he's under adalimumab, he's waiting for a phone call. He don't know if he's going to be called next week or in a few months. What do we do with our patient? Okay, so what about biologics and surgery? Can we prescribe them or not? But we have a very nice guidelines from the American Academy of Dermatology, and surgeries are classified among low risk, moderate risk, and high risk surgery. So again, we have a fantastic team in our hospital. So I went to the hepatologist and the general surgeon, and I asked them. And they considered this transplantation in the middle, a moderate risk surgery. So again, they said we need to individualize our patient. So we go to the patient. How do you feel? Well, if we at least knew that the surgery is going to be in 3 months, we could plan, but here we cannot plan anything. And the patient said, please don't stop my treatment. Okay. So before saying what we are going to do, let's see the whole picture. What happened after a transplantation in a patient under biologic? Well, again, 2 sides of a coin. We know that a person, after a transplantation, the course of IBD may be more aggressive, or even there are cases of de novo IBD. But also, we know that infections are the major complication after an organ transplantation. There are very limited data saying that the use of anti-TNF seems to be safe and effective after transplantation. So again, we need to individualize in our patient. So what are we going to do with our patient? He's now on the waiting list for the transplantation. So we accorded with him, again after a good conversation with him and explaining everything, that he's going to be under adalimumab. That once he received the call for the surgery, he's going to stop, and the surgeons are more comfortable with this decision. Why is he going to stop there? Well, he's going to receive anti-rejection medication, which sometimes includes cyclosporine, tacrolimus, prednisone. And remember, he was a super responder, and he was clear. So maybe we don't need any other treatment, but with a close monitoring of the patient. The patient feels very good because he has our number, and he can call us and then reconsider the biologic therapy. So this is what we are going to do, but maybe it's not the correct option. And so what did we learn from this case? That in complex scenarios, for us, it was critical to assess and to take into consideration the patient preferences and the quality of life. When a person asks me, in a person with a transplantation, what do you do? I always say, well, how is the patient feeling? And that's the most important thing. And then having a good conversation and explaining risk and benefits. That a multidisciplinary approach is crucial to learn in a super specialized healthcare system. And that in these cases, there is a fine balance between safety, efficacy, and many other risks that we have also to take into consideration. Again, an individualized therapy matters. So, grazie mille, muchas gracias, thank you very much.
A lovely case, very, very challenging. Any comments, Andrew?
So, nice presentation. It's not the drug that I would have chosen, though. IL-23 blockers great in psoriasis, great in IBD, I think, and safer, no risk of infection. So I would have just started a 23 blocker, kept the patient on, and that's what I would have done. I just want to, you didn't really mention that as an option, so can you comment on that?
Yeah, it was because the hepatologists were very conservative, and they always want some data to convince them. So we know a lot about the safety of these drugs, but I went to them with a systematic review and meta-analysis of adalimumab in primary sclerosing cholangitis, with adalimumab in organ transplantation. And they told me, do you have any paper of IL-23 in liver transplantation, in anything? No, I don't have anything. I know it's very safe. And they say, no, Álvaro. We know. And so that was the reason. But of course, I know that that, of course, would be a really good option.
Yeah, I think it's an option, isn't it? Do you want to comment?
So it's a great comment there. And I think also the problem you're facing here is similar to when you have a patient with multiple sclerosis at the same time as psoriasis. And we think now with immune suppression, they get that for the organ transplant. Our main problems are two, as you say. It's immunosuppression, too much immunosuppression if we give many drugs at the same time. And the other one is drug-drug interaction. Now, the biologics in general have a very, very good profile in terms of drug-drug interaction. It's not a major concern. And the other thing is there, the immunosuppression. And that's back to, I agree with Andy. I would say sometimes we're limited because what do we have data on? But that data is never from a randomized trial. It's published on case reports. And this is how we generate the data. So my way of approaching it would be, is there a relevant drug-drug interaction? Or am I concerned about too much immunosuppression? And I think, as you say, for the IL-23 inhibitors, those would be a really safe choice as well, even though we don't have published data on it.
No. I mean, okay, one more comment, yeah.
Okay, thank you for your presentation. Do you think about trying a JAK inhibitor, like tofacitinib?
Well, if I'm not using IL-23, maybe neither JAK inhibitors, I think. So, as I said, being part of a team is always good, but we have these nice drugs and all these reasons to use this, and we thought it was like in our setting and with our team the best option. And
I think also the infection risk is probably greater with the JAK inhibitors, I would say. And it's a small molecule as well, so if you have impaired liver function, there's problems with actually handling the drug as well. So I think a biologic's a good choice, and a TNF antagonist is a very reasonable option. So well done. Thank you very much.
Thank you.